We are live now.
Good evening, everybody. We welcome you to the PSI webinar series on gender-specific endocrinology that has been starting from 5th of July onwards. We will be conducting every week a webinar on gender-specific issues. Initially, we are touching upon the transgender issues in the first month. Second month, we will be doing something, the differences between males and females across all endocrine disorders. And third month also, we will spill over into something like a PCOS in men or maybe a osteoporosis in men and something gender-specific issues for the next quarter, year onwards. I welcome the chairpersons for today's session. We have Dr. Sanjay Sharma, who is from the Association for Transgender Health in India. And we have another chairperson, Precious. So over to the chairpersons for conducting the session.
Good afternoon, everyone. I think Dr. Sharma, you are on mute at the moment.
Admin, please unmute Dr. Sharma.
Yes, Dr. Sanjay, we have sent you request to unmute yourself. If you just click on yes.
Ma'am, you can conduct in the interim period. You can continue. You can.
So for this afternoon, then we have a very interesting presentation coming up. But first, we will have a quiz that will be presented by Dr. Sandeep Chatterjee. There will be a series of questions that for which the answers will be presented after the end of the presentation. So I think Dr. Sharma is having some issues in terms of to connect to us. So without any further ado, I would like to maybe pass on the screen to Dr. Chatterjee from Kolkata to present the quiz.
Yes, hello everybody. Let us go straight to some questions. I wouldn't call it a quiz. I would perhaps call it a reminder sort of issue, just so that our minds are focused. Let's see. So, the first question, how many types of genders are recognized? 2, man and woman. 3, man, woman and third gender. 4, man, woman, trans man, trans woman, or more than 4. So that's our first question. I think you better write down A, B, and so A, B, or C, or whatever, because you might forget it. Anyway, identify the correct statement about sex and gender. Sex refers to physical attributes, gender with chromosome structure. B, sex refers to external appearance, gender to internal anatomy. C, sex is assigned at birth based on phenotype, gender refers to socially constructed appropriate roles, behaviors, and activities. And D, sex and gender are the same. Third question, which one is true of non-binary persons? The non-binary concept is fairly new. Most transgender persons are binary. Most non-binary persons elect to have surgical procedures, and persons with intersex are usually not binary or perhaps DST. Right, question 4. Which of the following are health risks for transgender and non-binary adults? Substance use, major depression, anxiety, increase in suicide attempts, and E, all of the above. So which is true? Simple A and B, sexual attraction may change over time. Sexual attraction is fixed and does not change. Well, let's go on to question 6. As per the Indian census of 2011, what is the transgender population of India? This is as per the census. About 1 lakh, about 100,000, about 500,000, about 5 million or 50 lakhs, about 7.8 million or 78 lakhs. Next question, what is the most important social problem for gender non-binary persons? Is it a transphobic harassment? Is it lack of family support? That's B. Is it C, inability to use public restrooms? Or is it D, access to general care? The 8th question, what is the challenge in the management for transition for gender non-binary persons? A, it is unique for every individual. B, uncertain destination for most. C, the goal is not static and changes with time. And D, all of the above. Now the second last question, a transgender man identifying as a man can be attracted to women. B, men. C, both men and women. D, none. And E, all of the above. Well, the last question, which is true? Gender incongruence and gender dysphoria are the same. Treatment can be initiated after a green signal from a mental health professional. C, no consent can be taken unless the person has had his or her 18th birthday. And all of the above. And lastly, none of the above. That's D and E. So that's the end of the quiz questions, and we'll have the answers at the end of Dr. Anirban Majumdar's talk. So over to Chairperson.
Thank you very much, Dr. Chatterjee. I'm not sure if Dr. Sharma would like to add a few words.
Can you hear me? I'm able to unmute myself. So if you could get my video going, I'll be on now.
Perfect.
Request the organizer to put my video on. Okay, hi. So I'm Air Commodore Sanjay Sharma. I am the CEO and Managing Director of Association for Transgender Health in India. And it's God sent that I was not able to work my audio and video earlier because that allowed the questions to come in. And that has helped me because now I'm able to explain what my organization is all about. See, I also had these very questions in mind when my elder daughter came out to me as a transgender person just about 3 years back. And I found that I do not have answers. And what was worse was that when I went around and asked my colleagues, I found that they also did not have clear answers. And that is how I came on to get this organization in place. And I thought of 2 subsidiary arms. IPATH is the Indian Professional Association for Transgender Health. This is a platform for professionals who are already working in transgender healthcare to come together and plan research activity, share their experiences, and define protocols which would put transgender healthcare in the mainstream. Fill in the lacunae that are there in the existing system. And that is when I came in contact with excellent professionals from the Indian Society of Endocrinologists. And here I am speaking to you. The second subsidiary of ATI is called KAME. CAME is an acronym for Knowledge, Healthcare, Empowerment, and Mainstreaming, and it looks after all the social aspects. So that is what Ati is all about. And I will go on to my next task of introducing the speaker, which is Dr. Anirban, who is a teacher of Power Excellence and has done human work in endocrinology. And most importantly, he is instrumental in writing the Indian standards of care as far as endocrinology goes. So, without wasting further time, I'll request Dr. Anirban to please come on. Over to you, Anirban.
Thank you, sir, for your nice introduction. Good afternoon, friends. As you know, customarily and conventionally, we divide the human population into two gender, male and female. And today, I am going to talk against this customary classification, and I'll talk about non-binary approach to the gender. For this presentation, I do not have any conflict of interest. I treat only adult patients, and all the persons shown gave explicit consent that their pictures could be used. So I'll go through the few agendas. I'll give a short introduction about my talk. I'll discuss about my experience with this kind of people, and then I'll talk a little bit about the third gender, then the health risk, and the take-home message for the presentation. Now, this is the case I have seen roughly around 2 decades back in our endocrine clinic. And by looking into this person, I thought there is something abnormality, and I thought that there must be something problem in this individual. So I could not make out at that point of time. So I asked this person to undress, and after undressing, I found that actually it was a complete man, and this is the first time on first exposure as far as myself is concerned about the difference between the gender expression and the biological sex, which may not match always with each other. So if I ask this simple question, how do you describe your gender, then majority of us will not have much problem answering into this straightforward question. So we can answer this question, but some of the people are actually confused. And if you ask this same question, then they can have a varied answer. Some of them can tell you that I just don't have a gender. So the gender as far as varied as people, and you cannot just tell from looking into them, as I have already shown you. It is often complicated to figure out and cannot know the identity unless you ask. So therefore we have to ask. This is a very important learning, that we have to ask about the gender. We cannot assume the gender of a person. Now, so coming to the concept of gender non-binary, we often give a term gender queer. It can be used almost synonymously. So this is basically a spectrum of gender identities that are not exclusively masculine or feminine identities. It is basically an umbrella term under which actually we keep all the people, those who are outside the binary of female and male. Anyone whose gender identity is outside male or female, we can keep under this terminology, this umbrella term of gender binary, gender non-binary, or the gender queer. Now the issue is that many of them actually face a very, very important social challenge when they come across to a restroom, when they have to use the restroom in the public. So that is a very, very important challenge in front of them, because every time they have to force to tell about the gender in public, and every time, all the time. And choosing a bathroom is almost synonymous to the choosing a gender, which creates an exhausting, continuous anxiety. So with this small introduction, I'll discuss about my experience as because we run the first transgender clinic of the Eastern India in our hospital. So because of this clinic in the hospital, I came across to many people who have different kind of gender identities. Now, most of the patient what we see and deal in our clinic is basically transgenders, no doubt about it. So transgender may be of two, transgender woman and transgender man. And transgender woman has got a chromosomal sex of XY. They have gonadal sex of testes. They have male genitalia, but they perform a female gender role. On the other hand, transgender man has got a chromosomal sex of XX. They have ovaries, female genitalia, and they perform the male gender role. They feel that they are entrapped into a wrong body, into a female body, but actually they are man. These transgender people constitute the majority of the people we see in our clinic. Now, this is a young man who came to us for the transition therapy, and we treated this patient with the hormone therapy, and then he underwent through the gender affirmative surgery, and you can see over a period of time there is a complete transformation, and we call them transgender women, or you can call them as trans feminine. Just the reverse, we have another young women who came with an unsuccessful breast surgery. Then we advised her to go for a redo surgery of the breast. We treated this patient with testosterone therapy. She underwent the gender affirmative surgery, and now we can call them as trans masculine or transgender man. Now, these are the common example I think all the endocrinologists have seen in their clinical practice. Now, this is a 32-year-old from Bangladesh consulted our endocrine clinic for female hormone therapy. She ran away from her family at the age of 16 and joined a Hijra community. She underwent castration 14 years ago by a quack inside the Hijra community quarter in a remote village of Bihar. And you know, these people, they actually undergo very bad quality of surgery, and the castration was done by the quack. And I can show you the picture, and you can see that they are left with no genital organ. So these are the very common experience of us, and we see majority of these patients are coming from the Hijra community. Now, this is a young boy came to us in 2001 with puberty gynecomastia. So his parents were quite anxious about the puberty gynecomastia, but he was not very apprehensive about the gynecomastia. Now he left our clinic and he came back in after a decade in 2010. But at that point of time, I found that he was quite depressed, confused about his identity. So I asked him to go and consult a psychiatrist. So I had the diagnosis of gender dysphoria, which actually at that point of time we used to call this term as a gender dysphoria. So he consulted a psychiatrist and the diagnosis came. So we actually subject him to the hormone therapy, and then he underwent to the transforming surgery. And as you can see in 2013, after the hormone and gender affirmative surgery, it appears that she was quite happy with the process and the transformation. Now, this is another young person with trans masculine who started the hormone in 2011 at the age of 20 and mastectomy done 2012. Nothing novel in it, but the issue is that that he came to me in the follow-up with his girlfriend now in 2015. Now, if we look into these two young person and in perspective of their identity and the attraction, you will find that this is basically a transformed or the transgender man. So transformed from female to male, biological sex is female, gender identity manness, and sexually attracted to women. This is a complete female, biological sex is female, gender identity woman, and sexually attracted to masculinity and not man, because he is not a complete man. Now coming to this example, Miss SS, 20 years, a student of comparative literature, assigned female sex at birth. Sexual orientation female, mentally and physically attracted to female, and her mother was worried because of her this kind of behavior. She was not interested to change her gender. She was not transgender. She had anxiety and thought herself alone and insecure, which is a very, very common problem among this group of people with depression and anxiety. You can understand that she is basically a lesbian. Now you can see this 20-year-old boy came to us uh, and he demanded that he was actually gay. He assigned male sex at birth, sexual orientation male, mentally attracted to male, and disliked interacting with women. His mother was worried because of his behavior. He had no anxiety, but he was a huge challenge for his parents. Now, this is another young man at the age of 20 came to us. He had a tendency to talk excessively, and he had a woman-like behavior, woman-like walking and gesture, and physically attracted to female. His mother was worried about the hormone defect, and she told me that he must have less amount of male hormone. So, doctor, you give some male hormone so that he becomes complete man and he don't behave like a woman in front of the others. He was bullied by the peers since adolescence for the female mannerism. Not interested to change his gender. He was not transgender, but he had that kind of behavioral problem. But the issue is he had suicidal attempt twice, and that is an important challenge in front of us. This is Miss Air, 26-year-old lady. She was diagnosed as congenital adrenal hyperplasia with salt wasting crisis at 10-day age, karyotype 46XX, clitoroplasty done at 2 years of age, and she was reared as girl. She had a spontaneous puberty at 12 years. Now she desires to be male and adopt a male typical behavior. This is an important challenge for the congenital adrenal hyperplasia patient who underwent the clitoroplasty at a very young age. And now sometimes we face this situation, and therefore many people raised this issue that whether male sex rearing is a good idea for the patients with congenital adrenal hyperplasia with XX background. Now this is another interesting young couple, and you can see this lady came to us for transformation to a male, and this young boy came for the transformation as a female. Now, while coming to our clinic, they get romantically attracted to each other. Now, if we look on the perspective of these two young fellow, as far as their identity and attraction is concerned, this is a person who actually transforming from female to male, undergoing the hormonal therapy at present. Biological sex is female, gender identity manness, and romantically attracted to femininity, not female, because it is not a female, it is not a complete woman, but she is attracted towards femininity. On the other hand, if you look into this person, biological sex is male and gender identity is womanness, and romantically attracted to masculinity, but not a complete man. Now we have a further complicated relationship in this couple. Now you can see this is a boy who wants to transform as a girl and having the long hairs and actually has a girlfriend, and you can see that this is he wants to transform from male to female. So biological sex is male, gender identity is womanness, and they are usually attracted towards male, but here this person is romantically attracted to a female. Now, if we look on the perspective of this young girl, you can see biological sex is female. She's completely normal young girl, and gender identity is womanness, but she is romantically attracted to both sex. So there is the issue, and that is why they are actually together. Now, with this in examples, if I ask this question, how many types of gender we have, then we can see that we have the two important extremes. One is the man and the woman. They are the two extremes. In between these two, we can actually place the trans masculine and trans feminine. But even if you look into this, then actually it is a approach is binary. So if you look into the man and woman, it is binary. If you look into trans-masculine and trans-feminine, then also the approach is binary. But within this frame, between this man and woman, we have to place all these individuals. And therefore, the concept of non-binary comes, and all these individuals actually comprises roughly around 0.5 or 0.6% of the total population. So if you consider the total number of world population or even the population of India, then 0.5 or 0.6% will be a huge number. So coming to the concept of the third gender, as you know, that the concept of the third gender is not new. The concept of the third gender was there since ancient time, and we can see this these pictures. We can see many mythological character. We can see it in our sculpture. You can see it in our temple. You can see in our art that this third gender was existed since ancient time, and people were aware about a concept of a gender which was beyond the conventional male and female. And this concept of third gender not only present in the eastern part of the world, but it was present in the western part of the world as well. As you can see, this is a Greek marble of 2nd century BC, and the figure shows that the presence of the breast and penis in the same sculpture. Now you must have seen these people in the roads, and these people are the Hijra community of our population. And this Hijra community, actually many of them actually transgenders, but I exactly don't know the composition, and nobody has worked in detail as far as their exact composition is concerned. But I expect that there are this is not a homogeneous population. This is basically heterogeneous population. We have the transgenders, there is a transvester, there may be intersex disorder, and there may be many other varieties as well. Now, if we look into the concept of the transgender, Hijras are the officially recognized third gender in India. And as I have already told you, that the intersex disorder also come under the heading of third gender, as also the transvester and transgender. Sometimes we give this terminology gender queer, or we call it a rainbow community. So anybody, as I've told you, not heterosexual or cisgender will come under the heading of this gender queer variety. And therefore, these four important groups, the lesbian, gay, bisexual, and transgender, definitely comprises the major fraction of the gender queer family. But the issue is, we don't know the sexual identity of the many, and therefore we keep it as a questioning. And we also know some of the people have the two-spirited, there are evidences. So now the community extends to LGBTQ2, and now if we add the intersex disorder, and there are some people are actually asexual, and there are some those who work and talk about the transgender. So the spectrum actually increases to LGBTQIAA. And also we have some bigender people. Those the identity moves between feminine and masculine gender and behavior over a period of time. So it is a long list of people. This may not be the complete list, but it is a long list. So we cannot just identify the whole humanity, or can classify the whole humanity between male and female, or we cannot classify just between the male, female, and trans men and trans women. So if we look into this important cartoon, that will give you an idea that how we should look and approach into this important area of issue. Now we have to identify there are three important points. One is the biological sex, which is very easy to understand. And second is, what is the identity? And identity actually is inside our brain. And third is the attraction, sexual or romantic. So these are the three important parameters which we have to understand as far as each and every individual is concerned. And all three actually should remain aligned if you are not transgender, if you are cisgender and heterosexual. But if you are not heterosexual, if you are not cisgender, these three will not remain in alignment, though these three also importantly influences the gender expression, but it may not match with each other. So therefore, if I look into this spectrum of the people or spectrum disorder, it is something rainbow. So they actually varies from one to other. And if we put them into the two extremes, straight male and straight female, and if I keep in the middle the questioning group where the identity and attraction is questionable, and we have lot of shades in between, from gay to bisexual to transmasculine to asexual, female asexual, then transfeminine, then bisexual, female lesbian. So there are a lot of shades in between, and therefore we cannot make a simple statement of male and female or trans men and trans women. So why we should know about it, why we should learn about it, this is the question. And because of the fact they have a lot of health issues. Now, if we look into the prevalence of type 1 diabetes in our country, it is roughly around 1 lakh. And if you look into the census, last census done in 2011, and if you look into the total number of transgender population in our country, it is roughly around 5 lakh. Now, this is 5 times more, though I say that it is grossly underestimated. If you think that the prevalence is roughly around 5%, 0.5 or 0.6%, then the number will be huge. Anyway, even if it is 5 lakh population, then it is 5 times more than the type 1 diabetes. Every physician knows a little bit about the type 1 diabetes, but very few physicians understand the transgender issues. Now, most of the research on the transgender health tends to consider transgender individuals as belonging to a homogeneous population and stratify as trans women and trans men, a very wrong way to approach. They are target of oppression, discrimination, and stigmatization, leading to negative mental health and physical health outcomes. They perceive mental and medical health professionals are unfamiliar with non-binary genderqueer identity and their needs, and a very, very correct statement. And as I've told you, most of the physicians don't understand their needs. So if we look into the psychological issues associated with non-binary genderqueer people, this publication came in 2019 and looked into the prevalence of different mental health problems among the genderqueer people. You can see that the post-traumatic stress disorder, anxiety, depression, bipolar personality disorder are very common among them, especially the anxiety and the depressive disorders. They have lot of substance abuse disorder as well. Not apart from smoking, the alcohol and cannabis use is very, very common among these people. The most important challenge in front of us is the suicidal thoughts and behavior. This, again, a systemic review published in 2019, and it shows that the roughly around 46% people actually have the suicidal ideation, and 27% actually had a suicidal attempts. This is this is an average figure all over the world. And if you look into our data, we have very little data from India, and we have this statistics of 31% transgender person had a suicidal attempts. So this is basically very close to the world data we have. So coming to the issue is how we should help these people. We have to help these people to make the transition, and transition actually two part. One is integration and alignment. Integration means the process of finding comfort in oneself, and alignment means you have to align the public gender with that of the private gender. As you know, public gender is quite visible from outside, but the private gender is inside, that is inside the core of our mind. But sometimes the public gender may not exist, and how to approach if the person do not have any public gender. In that case, we have to try our level best to close it to the level of comfort as far as the particular patient is concerned. There are a lot of challenges in the transition because it is quite unique for every individual, and it is uncertain. As far most of the people are very, very uncertain about their destination. And not only that, they keep on changing their destination. So the goals are not static. So how we approach as far as the management is concerned, we have to understand the client goals. We have to understand the compromises, the amount of compromises that they can make. And at the same time, that how much hormone therapy and the transgender and the surgery can actually help. And we have to work with uncertainty because the goal changes, and therefore their journey also changes. Now, medical transition does not legitimize or delegitimize anyone's gender, because very recently the NALSA judgment came in 2014, and Supreme Court has given this the right to self-identification of every individual about the gender as male, female, or third gender. So the take home of today's presentation is that no non-binary genderqueer identities should be recognized by the healthcare service system. Specialized training for healthcare providers to become gender literate is the need of the hour. Guidelines should be revised, including not only the options for trans women and trans men, but also options for other genderqueer people, as well as giving clients the option to qualitatively describe their own gender self-identification. Create a welcoming clinical environment, not only for transgender individuals, but also for non-binary genderqueer people, all non-binary genderqueer people, to disseminate right information and reduce the health risk. So I'll conclude by taking a line from Tagore, Aro alo, ei noyone prabhu dhalo. Thank you very much for your patient listening.
Thank you, Dr. Anirban, for a very lucid presentation. And you have very rightly brought out that gender cannot be fixed into the binary. Gender is a spectrum. In fact, people are going further to say it's a web. And gender is unique to the individual, as unique as a thumbprint. And the perception is unique to the person. And it's also a very personal issue as far as the identity is concerned. You have also very rightly brought out that gender identity may be different from gender expression and may be entirely different from orientation or sexual preferences. These issues need to be understood by the medical practitioners, especially in today's time when WHO has coined this word called gender incongruence. So it is brought out that gender incongruence is not a mental health disorder. It has placed it in sexual health issues, and it has given it an ICD number 2. It is also telling us indirectly that one needs to understand and accept diversity. We need to understand that there is no pathology involved, and we need to relook at what we know and learn and teach more. Thank you for a lucid and very nice presentation. You have covered all aspects of gender incongruence, so to say. And gender incongruence is the new term which will be used by the medical professionals. However, the umbrella term continues to be transgender, and this is more used by the social grouping. One more clarification that I will add to what Dr. Anirban has already said. It is about what we commonly see as the Kinner and Hijra communities that are there. These are communities, these are clans. They have a homogeneous grouping. You have people who are cisgender and transgender. Also, you may have gender variant people who are grouped together. They follow their traditions and culture, which is very different from what is followed in the mainstream. So that is about Hijras and Kinners. Thank you so much. I will pass it over to my co-chair, Dr. Anjali, if she can add on something more.
Thank you very much. Thank you so much for a great presentation. I think it's a very good introduction to this month's series on lecture on gender care and transgender. I think for me, I also really appreciated the clarification on terminology, which has, I think, kind of changed and evolved a lot in the last few years. So this has brought a lot of clarification on the different terminology and how best to refer and discuss these terms. So I think a lot of the, like your presentation, I think did cover actually a lot of the questions that we had earlier on. So maybe it might be a good time at this point to go through them again, and maybe if anyone have any more questions from the panel or from our other attendees, it could be something we could do in parallel.
We are supposed to have the answer to the quiz.
Exactly. So should we go through the quiz again and the answer then, Dr. Chatterjee, if that's okay?
Yeah. Wow, nice, excellent talk. And basically, I think listening to the speakers so far, we get this overwhelming sense, which I also share, that we are trying to do our best for our clients, that we are trying our best to be as correct as possible. And there is a struggle within ourselves to overcome our own preconceived stereotypical views, because we are not used to a client coming and saying that this is the treatment I want. We are used to saying, you have come to me and I'm going to tell you the treatment you need. So I think it's a learning curve for all of us. And I think, it's a challenge for all of us. And it's the overwhelming sense that I get. I'm sure let's go to the questions and answers. Let's see. Okay. Yeah. So how many types of genders? Anirban has already said there are certainly more than 4 genders. And if you look at ABC, that is the American Broadcasting Corporation website, they have got about 54 different types of genders that can be recognized. Well, next one. Regarding sex and gender, sex is assigned at birth based on phenotype, and by laypersons in most of the cases. And gender refers to socially constructed roles, behaviors, and activities. And there are situations where sex and gender has been equated, but I don't think that is really the answer we were looking for. Next one, which one is true of non-binary persons? A non-binary concept is certainly not new. It is a very old concept. And most transgender persons happen to be binary. That's a finding from most studies, and the other answers are just sort of little red herrings. And which of the following are health risk for transgender and non-binary adults? As Anirban has just now said, all of them and more, certainly not less. Which is true, sexual attraction can change over time. Of course it does. This is a very famous actor, Jeremy Brett. And he's famous for his depiction of Sherlock Holmes on Canada television. He first married, had a child with a woman, and then went on to have 2 male partners, and finally a female partner, and ultimately died at the age of 62 of rheumatic heart disease. And he was also actually happened to be on lithium for bipolar. Anyway, he was a fantastic actor. So this is how things change. And as Anirban said about census data of transgenders in India, self-reported is about 5 lakhs, which is of course a gross underestimate. And most important problem, one of the important problems, of course, is that inability to use public restrooms unless you go to the ones with the doors, and it is actually a very difficult problem. So what is the challenge in the management for transition for gender non-binary people? It is unique for every individual. It is an uncertain destination, and the goal and the goalposts keep changing. So it's all of the above. And a transgender man identifying as a man can be attracted to women, men, both, or none. So it is all of the above. And which is true, gender incongruous and dysphoria mean the same thing. No, they don't. Treatment can be started after green signal from a mental health professional. No, it can be done by an interested physician. No consent can be taken unless the person has had his or her 18th birthday. That's not true. Consent can be given as soon as a person understands what the consent is about. So all of the above are not true, and none of the above is actually the correct answer. So thank you very much. So those are the questions we had. Over to Chairperson.
Thank you, Dr. Sudeep. Just one thing that I would like to highlight, that language is a very dynamic thing, and language changes with where you are speaking, with whom you are speaking. And if we want more and more people to walk into our clinics and be comfortable and take benefit of all the scientific advances that are made, take benefit of all our knowledge base that we have, then we need to learn their language. We need to know that there are few terms which are considered derogatory. For example, third gender is a derogatory term and we will avoid it. When we are addressing people, we will ask rather than assume. We will go by what is given to us. We will believe the narrative and we will work with the narrative that is given to us. Another thing that bothers us who are in healthcare, and especially when we are working in private places and in government institutions, is documentation. And the documentation really foxes us because we are now faced to right patient identities have to be made. An HIS system is already there in place where the person is declaring something, and if you write that, then he may not get some benefits, or the government may not agree with what you have written. So we need to learn a two-step system of documentation. The documents that are offered to the individuals, they need to be as affirmed by them. And the documentations which are to be retained and shared with other agencies have to be the ones which are matching the official documentation. The key word here is to be sensitive. The key word here is to be affirmative and empathetic. That is all that I can add to such a beautiful presentation which has already been done by Dr. Anirban, and the questions put in by the quiz master. Thank you.
We have a couple of questions from the viewers. I will share with Dr. Anirban. The first question is from Dr. Shivan. Sometimes parents bring their child. He is a boy but behaving as a girl. On examination, he is a normal male. What to do in such cases?
As I've already said that I am an adult endocrinologist and I don't treat children. This is my first declaration. Now, having said that, I must tell you that even if they are behaving abnormally or of opposite gender, then over a period of time, many children will find that this behavior just reverses, and nothing we have to do. So that is why it is better not to start any transgender directed therapy at a very early age. But if you have a strong suspicion that this is basically strong suspicion of gender incongruence, then actually you can go for psychological counseling, including the parents. Quite naturally, they have to accept that his or her child is basically transgender. And sometimes, really though, as I've told you, I have not done, because I usually don't treat children. I treat only adults. That you can go by puberty suppression therapy. So puberty suppression therapy you can give when the child will become adult, and then you can the picture will be clearer, and then you can decide whether he or she requires any therapy directed to gender transition or not. But we also have to understand that many of the children can have this as a reversible problem.
Yeah.
I think Dr. Anjali, she is a pediatric endocrinologist. I think she can.
No, she is not a pediatric endocrinologist. She's an adult.
I will add to what Dr. Anirban said. The correct thing, what is now being done, and this is what is being followed in the pediatric community. It is endorsed by the American Academy of Pediatrics. and is also something which we as ATI are pressing for in the Indian Academy of Pediatrics. The thing to be done is affirmative care. That means when the child says that he is male or he has a gender which is declared by that child, we affirm that. That does not mean that we start treatment, but this very fact that the parents do a affirmative narrative starts the mechanism of watchfulness. And as you employ other members of the gender affirmation team to give their expert opinions, we find that if this thing persists till adolescent, then or till Tanner stage 2, then we can take a recourse to pubertal suppression therapy or get the endocrine specialist to act. We also start taking help of the mental health professional, not a psychiatrist, but definitely a counselor, so that this counselor helps the child understand the shifting stages or the mental phases that a child goes through. See, we all have undergone puberty and we all know that how difficult puberty is. Even today, when I identify as a cis male, I remember so many confusions that I had in my growing up days. And this is the place where the mental health professional, the endocrinologist, who's part of the gender affirmation team, helps out. So any narrative that comes has to be first believed. Parents have a different viewpoint, and being a parent myself, I can empathize with the parent of the boy who is appearing with feminine features, because the parent is concerned that the society may not treat this child well, and this parent has come to you for advice from that angle to get that reassurance that there is nothing wrong with the child. That it becomes our duty as medical people to reassure the parents that, look, this may be a temporary phase. Let us get the gender affirmation team into place and let us watch and wait. Don't worry, there is nothing wrong with the child. Let the child do his academics, let him grow and develop. And if at all there is incongruence, then that is not a disease. And we have expert help available. We have the backing of science to ensure that your child will be a productive citizen of this country. So that is how we need to address these cases. Parents really have no choice when they come to a professional, and the professional confuses them with saying that, okay, this may just change, or is not ready to support their narrative. And support is the most important thing for management of any child who is diverse.
Is there any more question?
Another question from Dr. Manish from Delhi. Should endocrinologists start HRT for gender transition without a psychiatrist being involved in the care of trans person? I mean, counseling is of utmost importance, or part and parcel of the treatment. But should you involve a professional counselor and a psychiatrist, or you're comfortable doing and then you start off the therapy?
This is a very debatable area. I think we have recently published our guideline from the IDEA. So in the guideline, we have mentioned either one psychiatrist or one psychologist should be involved in the process of diagnosis and then to start the therapy. But if you look into some of the Western societies, they are shifting from the from making the diagnosis and starting the therapy without any psychiatrist or psychological help. So there are so you can do it if you are confident enough without taking the cue from the psychiatrist or psychologist. But as a matter of fact, in my clinical practice, I always take help of a psychiatrist or psychologist to make the diagnosis, especially because of the fact that many of them has got comorbid depression and anxiety that should be addressed. So that is why it is better to take help of them also.
Yeah. In extension to the first question about the child behaving of a different gender, the another question was: is karyotype necessary in these subjects?
No,
No,
not
not
necessary.
at all.
Not necessary. Not necessary. It's not necessary. It is because if you are thinking about gender incongruence, if there is no intersex disorder, then karyotyping is not necessary.
Okay. I want to ask Dr. Anirban a comment about transgenders participating in sports and additional advantage or disadvantage, or I mean, all
So
those.
I have the once I had the opportunity to come to the TV because of the fact that there was one transgender person who participated in the sports, and later it was found that he's basically a transgender woman, and then there was a lot of trouble as far as the sports community was concerned. So I don't know what is the guideline by the sports community or the particular sports discipline is concerned, but I believe that if somebody declared himself or herself as male or female, as far as Supreme Court verdict is concerned, we have to accept his gender, whatever he says, whatever the person says. But the sports community can have different, criteria for the selection and the level of hormone and karyotype that I don't know exactly.
Yeah, actually, some of the controversies, I mean, they have defined just based on a testosterone level, your gender is either a male or a female. That's it. I mean, leave everything else aside. So,
Yeah.
I mean, that's how it varies.
There's been a shift in this, and the Olympic Association has permitted for shorter this thing in athletics. They have said a few events will be considered as per the gender that is declared by the individual. It's a matter of debate actually, because sports is a area where you are measuring physical excellence, and if a person is competing with a in the category that that person is wants to, that is how it should be. We need to open our minds to this debate. Already the athletics have taken this view, and testosterone do not define gender. Genome also does not define gender. So this is an area which is going to open up.
One last question from Dr. Kattabomman from Salem. Some adult males' body language mimics that of a female. Is it habitual or organic? What should we do?
No, you have to look into that whether the person fulfills the diagnostic criteria or DSM-5 diagnostic criteria for gender incongruence or not. But if he is not fulfilling the diagnostic criteria, then possibly we are not dealing with a gender incongruent person. And as I've shown you, one of my case actually had this kind of behavioral pattern. Women like walking and talking. So it possibly there is no issue of gender incongruence into these kind of people, but we have to take we have to talk, we have to take the diagnostic criteria of this gender incongruence to rule out the diagnosis, and then we can take it just as a behavioral abnormality and not an issue of gender incongruence.
Thank you, sir. Dr. Sudeep, sir, have you seen the quiz results, or should I say it?
You can certainly share the results with us all. I've not seen them.
Okay. Dr. Shruti from Tirupati stood first, Dr. Ghosh from Kolkata second, and Dr. Mandeep from Delhi third. Those are the
Excellent.
top three scorers.
Excellent.
The chairpersons can conclude after giving their final comments. Thank you, sir, for the quiz.
Thank you.
Well, thank you very much for a very informative session. I look forward to the next session in this particular topic. I think it will be very interesting and it's something quite new, but I think we urgently need to learn more about it so that we're able to give better care to our patient coming to see us. Thank you very much.
Thank you.
Thank you.
Thank you, sir.